A 60-year-old man came to the operating room for a gastrectomy. A thoracic epidural was placed for post-operative analgesia. After advancing the catheter, the anesthesiologist aspirated it to exclude intravascular placement. Unfortunately, blood returned and the flow persisted with continuing aspiration. Aspiration was effortless and several cc's of blood were obtained. There was no doubt that the catheter was in the epidural vessel. Intravascular placement of an epidural catheter occurs in about 3% of cases. In the obstetric population, the incidence is much higher due to engorgement of the epidural vessels. If unrecognized, this situation may precipitate local anesthetic systemic toxicity, including seizures, hypertension, bradycardia, arrhythmias, and cardiac arrest. While little can be done to prevent this complication, several methods are suggested for identifying intravascular catheter placement. Aspirating the catheter to check for blood or CSF is mandatory. A test dose with 3 cc's of lidocaine with epinephrine in 1 to 200,000 concentration is routinely administered. If injected intravascularly, this will result in tachycardia and hypertension. This test is important because aspirating does not always result in a blood return, even if the catheter is in a blood vessel. Other tests, such as the injection of air in combination with precordial Doppler, are impractical. The catheter was removed and the epidural placed at another thoracic level.